everyone, and welcome again to the Journal of Oncology Practice podcast. This is Dr. Bob Miller from Johns Hopkins. At the 2014 annual meeting of the American Society of Clinical Oncology, held in Chicago earlier this month, there was a lot of discussion on the topic of value in cancer care. There is increasing recognition that the rising cost of cancer care affects all participants in the system, but most importantly, our patients who may have to directly bear the heavy financial burden. And there is a growing recognition that high-cost cancer care correlates poorly with high-quality care and better outcomes for patients. But what has been less well described is the impact that the financial burden of cancer has on the quality of life of survivors. An important study providing valuable data on this topic was published online in the Journal of Oncology Practice on May 27th. This was a report on the 2010 National Health Interview Survey, or NHIS, conducted by the U.S. Centers for Disease Control and Prevention, or CDC. I am pleased to have the senior author of the seminal report, Dr. Anis Chagpar of the Yale School of Medicine, as my guest for this podcast. Dr. Chagpar is the director of the Breast Center, Smilow Cancer Hospital at Yale New Haven, and an associate professor in the Department of Surgery, Yale School of Medicine. She is also assistant director for diversity, health equity at Yale Cancer Center. She's been actively involved in ASCO, and in her spare time, she recently completed an MBA at Yale University School of Management with a focus on leadership in healthcare. Welcome, Anis.
Thank you so much, Bob. It's great to be here.
So before we talk about the specifics of your paper, I wanted to ask you why you think there's been so much attention paid to the cost of cancer care in the past couple of years. Have we been slow to recognize this as a problem, or do you think there's been some recent shifts that have kind of brought this into the limelight lately?
Yeah, I think that it's a combination of things. I think that there's no doubt that there's increasing mind being paid to the fact that healthcare costs in our country are rising at an astronomical pace and are simply unsustainable. As well, as you said in the intro, I think that there's a lot of attention now being paid to value. And are we really getting an adequate bang for our buck? So when we expend healthcare dollars, what are the outcomes that we're seeing? And I think that because of this, a lot of people are beginning to wonder about whether, in fact, all of the new therapies that are coming out are worth the dollars that are being spent, whether we should be investing a lot of money in the last few months of life, whether there is increasing value to end-of-life care, and so on. And so I think that this has been a burgeoning field and one where a lot of people, whether they are clinicians, researchers, or health economists, have started to really pay some serious attention to how we can improve care, both in terms of access as well as quality, but certainly in terms of value.
So you mentioned the cost of drugs, and specifically I think people think of IV chemotherapy and oral drugs as the most obvious examples. But are there some less visible financial burdens that patients and families have to overcome in dealing with a course of cancer treatment?
Absolutely. I mean, we think about therapies and the drugs, but there's all kinds of ancillary costs as well. Think about the costs of tests. Think about the costs of doctor's visits, deductibles and copays, and how people with varying insurance schemes have to pay for their care. But even outside of that, there are other costs of transportation, costs of time taken off of work to go and see the doctor or go for therapy, costs that are associated with disability when you can't work, costs associated with time away from various activities that you might otherwise be engaged in, and the surrogate costs of care providers who may be also expending their time on a patient's care. So I think that there are many things, be it from grocery shopping that may need to be changed, to transportation, to parking costs, all the way up to therapy, that it really is a very large cost when you think about it from a societal perspective.
I think you make a great point there, because I think it's easy for many physicians and providers to think about the cost of the drugs, but sort of miss these very obvious daily burdens that patients and families are facing every day just to get through the day and carrying on the activities of daily living. I think sometimes we forget about those things.
Yeah, absolutely. I mean, you think about patients, and I'm sure for them as well, the big cost that they think about is their out-of-pocket costs, their deductibles and their copays. But when they start adding up, well, who's going to look after the kids? And now I need to find a care provider, and now I need to find transportation. There's a lot more factors that are all adding into that cost that they need to bear.
So let me ask you about this survey. I wondered if you could tell us a little bit about the specifics of the NHIS process. I was really fascinated to read that it was administered face-to-face by trained surveyors entering data into a laptop. I mean, how 1980s is that? That's terrific.
It is. You know, the NHIS, I think, is a real gem in terms of health information. It is the largest source of health information of the U.S. Population. So it's a tremendous resource that we have from the CDC. It's been in existence actually since the mid-1960s and has been kind of refined over the years. And what's really nice about it is that there is a great deal of attention paid to the structure of the survey itself. It's designed to be representative of the entire U.S. civilian, non-institutionalized population.
Okay.
And that means that they really do structure it to in a kind of hierarchical clustered sampling scheme, such that they look at households and then families, and then take a sample adult and a sample child in each of those families to really ask questions that pertain to health information in general. Each of those individuals is given a weight that is representative of the entire population, and minorities, in fact, are oversampled so that you really do get very good variance estimates in minority populations. Because of this complicated sampling scheme, however, the statistics are a little bit more intricate. But truthfully, when you get used to using this data set, it really is a goldmine. Every 5 years or so, in addition to the core sets of questions that they ask, and the core sets of questions are everything from region, nationality, citizenship, marital status, employment, income, insurance status, all the way out to what did you eat for breakfast, how many fruits and vegetables do you get, do you smoke, have you tried to quit, if so, how, what is your alcohol consumption, how much physical activity do you get, have you had a whole range of disease processes, and so on. In addition to the usual battery of questions, about every 5 years or so, the CDC has administered what they call a cancer supplement. And the cancer supplement really is designed to get information pertaining to cancer. Everything from family history to screening to a past history of cancer to patients' perceptions of their rates of recurrence to how cancer has affected their life, both in terms of quality of life as well as financial distress. And so it really is an incredible goldmine when you want to look at issues pertaining to the population in terms of their health.
So I gather that your report that you published in JOP relates specifically to one of those 5-year surveys on cancer.
Correct. So we looked at the most recent cancer supplement, which was the 2010 survey, and linked it with the core survey. So we were able to pull information from the files pertaining to region and insurance and education and so on, link it with patients' perceptions of how cancer affected their quality of life, and particularly how the financial burden of cancer affected quality of life.
So I want to ask you a few specific questions that sort of came up in my reading. I guess I would start by saying that I was a little bit surprised that almost 70% of patients said that they were, quote, not at all burdened financially by their cancer, which I guess goes a little bit against the hypothesis. What do you think the reason for that was?
Yeah, so with all that we've said about the wonderful nature of the NHIS and how it's such a powerful tool, it does have some significant limitations. And one of those is that it is cross-sectional. So basically, this survey is taken once a year, and the CDC sends out 400 surveyors who go to people's doorsteps and talk to them with a laptop in their hand, as you mentioned. But that means that they are at varying times from their diagnosis of cancer. Oftentimes, this may be years or even decades from the time when they were diagnosed. So you would anticipate that there would be some recall bias there. The second issue is that some of these people may have said, yes, I had cancer, but they may have been diagnosed with cancer when they were a child. So maybe they didn't experience any financial hardship. And the third is that there may also be other things that were going on at the time that may influence how much they attribute their financial distress to cancer. So I thought a lot about why that was. You're quite right. You wouldn't anticipate that close to 80%, 79 point something percent of people would say that they didn't have any financial distress. Whether that might have been due to the fact that this did occur right after the financial downturn of 2008, and whether people were actually more concerned about, well, it really wasn't cancer that was causing financial distress. It was the fact that I lost my job, my house is no longer worth what it was worth, and so on. So you really do need to think about it in context.
So, yeah, no, that makes sense. I think this was a report on the 2010 survey. Is that correct?
Correct.
Okay. Now, if you could talk a little bit about some of the specific findings in the tables. Now, there was one, again, that I just kind of pulled out was the different cancer types that seem to be associated with the most, or I guess I should say a lot of financial problems. The top ones, I think, were thyroid, ovarian, and lung cancers. And again, I know the answer is probably not in the survey, but was a little bit surprised to see thyroid cancer in there, just knowing its prevalence and usual clinical course.
Yeah, you and me both.
Yeah.
So I was actually very surprised that thyroid ended up being in the top three. Certainly, some of the other heavy hitters I was less surprised by, but certainly thyroid cancer was one that kind of caught me off guard as to why that would be associated with more financial distress. Now, you'll recall, however, that was just on the bivariate analysis. So one of the things that we wanted to do was to see whether, in fact, this was associated with more financial distress, perhaps because thyroid cancer was associated with younger patients, whether it was associated with worse insurance or perhaps more uninsured patients with thyroid cancer. When we did a multivariate analysis and reported that on table 3 for anybody who's listening who might have the paper in front of them, we actually found that thyroid cancer was not really associated with changing the degree to which financial distress was associated with quality of life. So cancer type fell out of the analysis. But you're quite right. You wouldn't think that thyroid cancer would be a particularly expensive cancer to treat.
Focusing then, I guess, on the multivariate analysis, what were the characteristics of the patients that you found that reported the most financial problems? And I guess most importantly, and to what you were really looking at, how did these things correlate with self-reported quality of life? Yeah,
so when we looked at all of the things which were associated with financial distress, we found that women were more likely to report financial hardship due to cancer. Those of minority race and ethnicity, patients who were younger, had less education, less insurance, less income, and cancer type, as you mentioned. When we looked at the multivariate analysis, after we found that financial distress was associated very strongly with a whole variety of measures of quality of life, whether you look at physical quality of life, mental quality of life, the degree to which it affected your social relationships, your belief that the cancer would come back, and worry. When we stratified quality of life overall into good or better, and then looked at the degree to which people attributed financial distress in their life due to cancer and all of those other factors, we actually found that of all of them, financial distress was the most predictive of quality of life, which I thought was really fascinating because it trumped insurance status and it trumped education and it trumped income as well as race and everything else. So it really hit home for me the fact that the degree to which people are experiencing the financial burdens of cancer care really does impact their quality of life far more than many of the other things that we think about.
Well, that's a really powerful point, and I think that's something that's likely to be lost in these discussions because a lot of discussions I've heard about value sort of treat the financial toxicity or financial distress part of it as an add-on to all the other things that are troubling and can affect quality of life. But you're saying that, at least in this survey, that was the number one predictor for poorer quality of life.
Absolutely, and quite dramatically so.
Interesting. You alluded to this a little bit about a connection between female sex and increased financial hardship. I thought that was pretty fascinating. Can you go into that a little bit more?
Yeah, it was interesting when we found that and we looked into the literature further. We weren't the only ones who have found that women actually, in a number of studies, have been found to experience more financial distress due to health-related costs in general and cancer more particularly. And there's a number of reasons why you might think that women would be more likely to feel the burden of financial distress due to healthcare. In part, they may be disproportionately affected by childcare expenses. Oftentimes, they carry the burden of, looking after the family, making sure that there are groceries and so on and so forth. So part of it may be that they feel it more, and part of it may be that they simply feel more responsibility and more distress when there are those extra burdens.
And they may be more likely to mention that to a surveyor, I'm guessing. Yeah, it could well be, and when you think about all of the other things that we talked about at the beginning of this podcast, things like childcare, groceries, transportation, oftentimes that falls in the lap of women rather than men who Sure.
who may rely on their female counterparts to help out with a lot of those
Sure.
things.
So I know this survey really wasn't designed to assess anxiety or depression, but do you think that the self-reported quality of life measures, do you think that's a reasonable surrogate for anxiety or depression, or is that too much of a stretch?
I think that's a really interesting question. We looked specifically at the quality of life metrics, but as I mentioned at the outset, the NHIS is a huge repository of data, and they actually do have fields on depression and anxiety. So one of the things that would be very interesting, and Bob, I might just take you up on this idea, is to look at financial distress and whether in fact that correlates to depression and anxiety. And perhaps, though, we would need to look at whether that changes over the course of time because, as I said, with this being a cross-sectional survey, all of these individuals would have varying times since their diagnosis and treatment. But it would be interesting to look at whether financial distress or those who claim to have a higher rate of financial distress due to cancer burden had a prolonged history of depression and anxiety as a result. So that's something that we could look at. We didn't in this particular study, but I think that's a great idea.
Now, I think it's probably important to remind the listeners that this was, as you said at the outset, a cross-sectional survey. So this wasn't a survey done in a cancer center. This was done in the general population. And so, you're going to hit a relatively small percentage of people that have had a cancer diagnosis. And so I think that we might be interesting to see what the results would be if you did this same survey in the waiting room of Yale Cancer Center or something. But
it's actually very interesting that you mentioned that. So 2 points. The first is that in this study, remember that the NHIS is designed to be representative of the U.S. population. So even in this survey, they had surveyed 2,151 cancer survivors who represented about 17 million people in the population. But they actually spoke face-to-face to 2,151 people who reported having a history of cancer, certainly a lot more than we would be able to get in the waiting room of Yale Cancer Center. But one of the things that is fabulous about being at Yale is that at Yale School of Medicine, all of our medical students are required to do a thesis. And one of my students, Kathleen Fenn, who's actually the first author on this paper, was very interested in this whole topic and helped to do this study and write this paper, hence she's the first author, but actually had that epiphany that you just mentioned and said, what if we did a prospective study in the waiting room of the breast center at Yale and asked some of the same questions and got around some of the same issues that the NHIS has as its weaknesses. So, for example, what if we restricted our population to people who were diagnosed within the last 18 months so we could limit recall bias? What if we could then also factor in some of the clinical pathologic data, tumor size, treatment variables, and so on, to see how that played in, and was able to do, albeit a much smaller study, which she's in the process of writing up to look at those issues.
Well, we'll tell Kathleen we're anxiously awaiting her work because that sounds like a very important study to bring to light. Yeah,
I'll pass that along. Yet another person breathing down her neck for the paper.
Yeah, tell her there's a podcast in her future if she publishes it. So, and I guess finally, let me just ask you, what do you think the next step should be? So based on your findings, what are the important unanswered questions on the topic of financial burden in cancer care that you would like to see addressed with further research?
Well, I think that the possibilities are really endless when you think about further research in this area. We could certainly look at value, and I think that cost-value propositions are certainly where things are at. You and I at ASCO heard so much discussion about how we can deliver better value to our patients, and then to really see whether that's translating into improved quality of life. We talk about newer therapies increasing longevity by X number of months or X number of years, but really seeing when we look at cost benefit and we look at quality of life, whether in fact these expensive therapies are adding value. So I think that we need to really focus on how we can add value. I think the next issue is once we do that, whether patients experience better quality of life as a result. I'd like to see us survey clinicians to find out whether clinicians actually do talk to their patients about the financial impact of cancer care, and how much that factors into decision-making that is shared between a physician and their patient. I think that more and more we're realizing that these are real issues, dollars and cents, and it really does affect our patients. And so how much do we really focus on that? But I think that the list is endless as to the work that we can do, figuring out how we can deliver better care for our patients at lower costs so that we can really improve outcomes of entire populations.
Dr. Chagpar, thank you so much for joining me on this podcast and sharing your data with us.
Thank you so much for having me, Bob. This was great.
And thanks again to my guest, Dr. Anis Chagpar from Yale, for discussing this important paper with our audience. The full-text version of the paper is available online at jop.ascopubs.org under Early Release Articles, including some online-only content. Thank you, as always, for downloading our podcasts, and we'd love to hear your comments at jopeditorsdesk@asco.org or drop us a line on our iTunes page. This is Dr. Bob Miller for the Journal of Oncology Practice. Thank you so much for listening.